Hi, everyone. Thank you so much for joining. We're just going to wait a couple more moments for folks to come on the line. Okay, perhaps we'll get started, as I know we have a really exciting panel today and only 1 hour to discuss a topic I'm really passionate about, and I know all of the other panelists are as well: ethical considerations in the collection and use of socio-demographic data in healthcare. And we have 4 amazing panelists today: Dr. Astrid Guttmann, Karima Karmali, Melissa McCradden, and last but certainly not least, T. Garnett. You're going to have the opportunity to hear briefly from each of our panelists, and then we've got a series of hopefully really exciting questions, and then we will open this up and there'll be an opportunity to put your questions in the Q&A. Next slide, please. I want to start by acknowledging the land on which SickKids operates. For thousands of years, it's been the traditional land of the Huron-Wendat and Petun First Nations, the Seneca, and most recently, the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. SickKids is committing to working towards new relationships that include First Nations, Inuit, and Métis people, and is grateful for the opportunity to share this land in caring for children and their families. Next slide. So I won't read you these session objectives. Hopefully you saw these when you were signing up to come to this. But I will read this quote from someone I consider both a mentor and am privileged to call a friend as well, Camille Lorridge, who last year in the Black Health Symposium asked the question, what is the health outcome of a Black individual? How do they access or experience care? Is it the same as their white counterpart? Why not? These are the questions that every health leader in this province should be able to answer, and every board of directors. The reality is that we mostly don't collect this data. We aggregate health data in a way that obscures what's going on. I'll share one more anecdote as we are coming from SickKids today. This morning, I had a discussion with my 2 children who are almost 11 and almost 13, and I told them about collecting data that's about themselves, their race, their disability, their gender, their sexuality, and asked them how they would feel about this information, and said that a lot of people still don't collect it. And my son, who's almost 11, after muttering a number of colorful words I think he's picked up from watching Ted Lasso, said, I think that this reminds me of the allegory of the cave that Plato describes. Since it's Bioethics Week, I have to add this in. He said, if those people who were in a cave only know their own experience, how do people in healthcare know what programs that they're supposed to have? So anyway, on that note, I think it's the right note to begin. Next slide, with our first presenter, Karima Karmali, who is going to begin.
Thanks very much, Rachel, and hello to everyone. So I'm Karima Karmali. I'm the director for the Center for Innovation and Excellence in Child and Family-Centered Care here at SickKids. And over the next few minutes, I'd like to provide an overview of work at SickKids that's focusing on the collection of socio-demographic data from patients and family caregivers. But before I get into the initiative itself, I think it's really important to provide some context for this work. Some of you may be familiar with the quality framework that has become foundational to how we think about and define quality of care, and also how we report on it. The framework has 6 dimensions, and equity is one of these dimensions, which interestingly, but not surprisingly, has not received a whole lot of attention in the healthcare system generally. So while we have key performance indicators that we track to monitor how we're doing in each of these dimensions, we haven't actually done this for equity historically, nor have we been required to do this by Ontario Health, to whom we submit quality improvement plans on an annual basis. And while I think that there are many factors that have contributed to this lack of focus on equity, including the lack of data, I do think that it is really appropriate to apply an ethics lens to the reasons why we haven't seen more progress in this area. Now, I'm really pleased, though, that more recently Ontario Health has released its framework for health equity, inclusion, diversity, and anti-racism. And what I really want to highlight here is that the collection and use of socio-demographic data is central to this framework and is really seen as a means to address issues of racism and health equity in our system. So next slide, please. It's also great that our current strategic plan really commits heavily to action on the social determinants of health, to equity, diversity, and inclusion, and to precision child health. All of these things will help to advance health equity in our system, in our hospital, which is really great. And the collection and use of socio-demographic data is integral to the advancement of these objectives and to addressing systemic bias, racism, as well as other barriers to health equity. Next slide, please. So why should we collect this data, and how will this contribute to health equity? First, it will help us better understand who it is that we serve. Right now, we have no way of quantifying the diversity of our patient population. And these are questions that I get asked every day. You know, what proportion of our population, for example, is Black or doesn't speak English? And we simply don't have the data for this information. At the patient level, it will help us to individualize and tailor care to meet the needs of our patients and families. At an organizational level, it will help us to identify disparities in access, in patient experience, and in health outcomes, and make the appropriate plans to improve care and services. At the systems level, it can guide planning, it can guide policy development, and it can also guide funding. And finally, this data, I think, is also really important with some caveats to research. Next slide, please. So I want to try and just concretize one of the ways in which we can use data for improvements to quality of care. So having this data will help us stratify various quality metrics by these socio-demographics. So we can, for example, look at adverse events by race and language. Is there a disproportionate number of safety events or adverse events that are impacting people who are not proficient in English, for example? Now, we know through research that these disparities do indeed exist, but this type of approach can help us to address disparities within our own system in a methodical way. It will help us identify disparities in quality of care, in patient experience, and in health outcomes, and then develop and implement quality improvement initiatives to address these disparities. Next slide, please. So we're using the pediatric instrument for socio-demographic data collection that was developed by SickKids and Holland Bloor Review in 2014 at the request of the Toronto Central LHIN at that time. The instrument really builds on the tool that was developed for adult hospitals by the LIN and several adult hospitals and Toronto Public Health. And the pediatric instrument consists of 2 survey tools, one for patients 14 and above, and one for caregivers who would complete the survey for themselves and patients under 14, because we know that caregiver demographics, of course, really matter in pediatrics. The tool includes the collection of data on race, on language, gender, disability, sexual orientation, and income levels, among other demographics. And we did do extensive testing of this tool before we began to use it back in 2015. Next slide, please. So the collection of socio-demographic data is not new to SickKids. Several years ago, we had started data collection using manual processes, and the initiative was brought to a halt for a couple of reasons. One was that the manual data collection and inputting of the data was time and resource intensive, and at the time, there were no digital solutions that were available that could safely interface with KidCare, which was our clinical documentation system at that time. The second reason we stopped moving with this data collection was that we were beginning preparations, in fact, for the implementation of EPIC, which at the time could not accommodate this data. We have now identified 2 EPIC digital platforms that will allow us to collect this data electronically. So MyChart is the first, and it's a secure patient portal, as many of you will know, and it provides patients and authorized family members access to parts of the SickKids electronic health record from home. And the health equity questionnaire is embedded as part of an e-check-in process to be completed prior to a scheduled appointment, either virtually or in person. And a reminder notice is sent to users about an upcoming appointment 48 hours before the appointment, and the user can log in to MyChart, find an upcoming visit, and then check in and also complete the questionnaire from the comfort of their home. So this is being piloted with MyChart users in the rheumatology and neurology clinic. And we're just in fact getting ready for a hospital-wide implementation starting November 23rd of this month. Then there is Epic Welcome, which is another Epic platform. It'll allow patients and families to sign in when arriving at SickKids using tablets and tablets on wheels. So this is really for those folks who don't have MyChart. We have an alternate way of capturing data from these patients and families. So patients and families can verify their information and complete pre-visit tasks using Welcome, and the health equity questionnaire is one of those pre-visit tasks. And so the target implementation for this is later this winter and spring of 2021-22. So of course, not all patients and families are going to feel comfortable providing their data. And this is, of course, voluntary data collection. And so there's still a lot of work that needs to be done to figure out how we help people feel comfortable, particularly patients and families from specific communities like the Indigenous community and the Black community. And there's a whole lot of work that's being done or will be done in this area. I'm going to stop here and hand it back to Rachel and look forward to the discussion and questions and answers later this session. Rachel.
Thank you so much, Karima. In the interest of time, I'm going to pass it right over to T. Garnett.
Excellent. Thank you. Sorry for that technical glitch there. So thank you to those I have not met. My name is T. Garnett. I am the new Executive Lead and Strategic Advisor of Equity, Diversity, and Inclusion here at SickKids. And most who have seen me know that this quote from Bell Hooks is very near and dear to what I do here. And what it really does say is that a healthy organization, community, family really supports you in being distinct from, but include it with those around you. And how do we do that? How do we support our distinction while also being part of the collective? And so that's what we're really going to lean into these conversations right now. Next slide, please. And so part of this data collection conversation starts with who are we? And why is this so important? And so for most folks, we have been having these conversations about, our positionality, our social political identifiers are much of what Karima has indicated in those social determinants of health. And it really prescribes the type of life we're going to have, but it also situates those who have power and those who do not. And in the nature of language, when we think of power and privilege, we think of how that power and privilege is enacted upon the data collection. And one of the things that folks have heard me say is that we truly do measure what we treasure. And if we're not supporting folks who are not centralized in our employee spaces, how then are we supporting engagement? How are we supporting quality and safety? How are we supporting recruitment and strategy selections, as well as the ongoing financial economic component that comes with our retentions, that comes with our procurement, that comes with all of our economic capacities to impact communities that come through individual health and well-being as well. And so a lot of these conversations makes us comfortable with understanding that difference is to be celebrated as opposed to inferior or substandard. And so even terminologies such as visible minorities, what then are we saying about the majorities? And when these demographics change to represent different demographics will be the minorities, will we then change language? Next slide, please. So everything that we do is clearly located within a framework, and Ontario Health has introduced this framework, and Karima indicated how it impacts patient, family, and safety qualities, but it's also indicating that when we measure our staff engagement and measure the disaggregated data of our staff, we can then support the various ways to increase quality and safety in our employee base as well. And so when we talk about critical race theory and frameworks, it is so critical to understand that one size does not fit all. And so for myself as a Canadian Black person, 6 generations, I have a very unique experience of anti-Blackness on Canadian soil that will not be shared nor experienced by other racialized Black folks who come from different locations such as the Caribbean islands or Africa. And so we formally locate these frameworks in this yellow slide to ensure an anti-Black racism and anti-indigeneity analysis to clearly locate the differential experiences and opportunities that come within racialized bodies. And so again, going back to that previous conversation about who are we, and understanding and being comfortable with differences as opposed to saying, no, we're the same. Where is that discomfort coming in celebration of our differences? And why are we so uncomfortable when we talk about race-based data, when Canada has actually been engaging in data collections since 1931, I believe the first census was held. Yes, the first census was held just before actually the end of the World War II. And we started leaning into these conversations of ethnic origins as opposed to the first Canadian stats introduced the census of color demographics in 1901, which indicated, and I quote, white demographics, Black demographics, yellow demographics, and red. And so those were the color coded that were introduced, that we are now kind of agitating and disrupting those 4 categories of color-based data collection. Next slide, please. So again, we talk about data. It's not new. It's not new at all. We've actually been engaging in these conversations, as I indicated, since 1901, but we're more recently really trying to advocate for the need for data collection in response to this global pandemic. And so the global pandemic has hit communities differently. This slide here indicates the ages that we see folks who are 25 and older had a higher, much higher than other racialized groups of catching, more likely to contact COVID virus. And so when we again talk about these data collections, we talk about the impact of COVID, Now, I want us to ask ourselves, when we have been mandating essential workers, who are those bodies? What is the data that looks to represent the folks who have been doing the work for supporting COVID applications and responses, as well as impacted by COVID? And so we see again this correlation of an overrepresentation of racialized bodies being placed at risk as essential workers that support racialized communities more likely to contact COVID. And so we have to ask ourselves, how is this coincidence such a dramatic similarity, given the minute representation of racialized communities in Toronto? So for instance, the Black population is only 10% of the globe of Toronto's population, but this demographic continues to be overrepresented in regards to other healthcare and systemic inequities that we will have a quick little tiptoe through. Next slide, please. And so, for instance, we often talk about, structures. How do folks get into being hired within an institution, including SickKids? And so this is just an indicator on how stats impact employment sectors. And so when we think about the callbacks, right, I want us to think about, first of all, these are just the callbacks of the applications that we've even screened. But what we know, as evidence has indicated, that over 52% of ethnic sounding names will not receive a callback from HR simply because the name doesn't really fit. It's not our cultural names. It's uncomfortable to pronounce, it's unfamiliar. So therefore it causes us to feel some ways, and we're just not going to call them, despite knowing that these applicants have the education, experience, and qualifications that we are posting for and require, but it is our discomfort in different and unfamiliar names and ethnicities that we have then projected has not a good fit. And so again, we have to ask ourselves, we are collecting data, and we've collected data in multiple sectors across Canada and including in Toronto, but it is the healthcare sector that still remains a tad resistant in regards to the lack of data collection to guide and grant evidence into the situation we're working with. Next slide, please. And so again, as we live in a capitalistic society, we have to ask ourselves, what is the impact of communities when we talk about social economic data collections, and looking at the fact that a Black population fares much lower than other racialized populations or other non-racialized populations. And so again, looking at data collection in regards to economic health, in regards to access to resources, in regards to opportunities such as house purchasing, and how that continues to be driven by race-based data, that we see these things and redlining of communities that are the good neighborhoods, and how that language is deeply rooted in anti-racism rhetoric. And so this continuation to push back of not engaging, how then do we provide the best healthcare if we're not prepared to engage in creating spaces of differences and inclusion? Next slide. So again, data collection, we know that as a result of COVID, we have seen an increase of community violence and harm. We are seeing an increase of harm within our families, which are leading to healthcare, including the race-based data that has been targeted for anti-Blackness and xenophobia. And so these two rhetorics have increased in regards to the healthcare risks that COVID has placed within these communities. Next slide, please. So race-based data is a great conversation. Stephen Lewis actually introduced it, I believe, in 1990. So it's not new. And we've been collecting data since 1901, but it's a great start. But unless we're going to use this data as benchmarks, as evidence to our systems of change, to inclusive representation, both within our entry-level positions that we then support through our leadership, it is simply just a performance that harms folks as opposed to helps. Next slide. Multiple ways to collect it. All of this, as we have discussed, I am mindful that we are running a little bit short on time, and so I'm going to quickly rush through and hand it over to my next person. Next slide. And so again, we can only be included when we are truly able to bring our full sense of selves, the multiple layers and complex identities that are embodied in our identities and roles to the conversation, if we are truly going to engage in transformational equity. Thank you so much. I believe oh, thank you, Rachel.
Thank you so much, T. We're going to move straight to Dr. Astrid Guttmann. Over to you, Astrid.
Thanks, Rachel. Hello, everybody. Really delighted to be part of this panel, and you'll hear sort of threads from the first two talks as I reflect on work that we've been doing at ICES to develop a race and ethnicity data framework. So for those of you who aren't familiar, ICES is an independent research institute with multiple sites across the province. We are named in Ontario's health privacy legislation as a prescribed entity. And so we don't, unlike part of the discussion here, we don't actually primarily collect data, but we receive data from others, predominantly the Ministry of Health, and we are allowed to use those data as well as demographic data for research and evaluation on the population of Ontario. And I put the pictures up, to just, we constantly remind ourselves, we are data stewards of data on every legal resident in Ontario, and we take that role really seriously. And so while some of what we've been talking about is, the collection of the data, I think the ethical and responsible use, the governance of data is sort of equally important. And I'll reflect on, the fact that in building this race and ethnicity data framework, which sounds like a really technical exercise, data standards or things like that, it's really not. Like what this has become is really, much more about transforming, an organization into one that promotes anti-racist, intersectional and community-driven approaches to research and analytics. And again, thinks very broadly, not only about the use of the data, but even, the governance of those data. Next slide, please. So part of the key elements of how we've done our work has really been about learning and reflecting, and specifically on scientific and medical racism. So, T talked about the harm, and I'll talk a little bit about how that's kind of guided our thinking. So there has been a lot of harm in the way in which race, ethnicity, other socio-demographic data have been used in research. And I think we have to be really mindful of that and learn lessons. The other is we are working very collaboratively. So we're working we have a core committee at ICS, we have a larger committee, but we've been working with a lot of other provincial organizations, Ontario Health, the Ministry of Health, who are also trying to, better place and understand the ethical use of data. We've heard from T that we do collect a lot of data with the census data at the provincial level. We have not always collected race and ethnicity data, and Rachel, spoke to Camille Orridge's call for more data. There are more conversations and action around this. So specifically around COVID, public health units started to lead, but then the province mandated the collection of race and ethnicity and other socio-demographic data on COVID cases. Was also supposed to be with the vaccine data, although I think that wasn't implemented. But there are conversations, being had about these data being collected at the time of application or renewal of OHIP cards. So, I think we will hear there will be more work that will be done to try and collect some of these data. So I think getting ahead of that and really making sure that we're comfortable with how those data are going to be used and governed is really important. We've definitely sought expert advice. So I would say we're late to the party, and there have been people who for decades have been calling both for more race data, but also, ethical approaches to it. Camille Orridge is part of the Black Health Equity Group that released a recent framework around the use and governance of Black data and or data on Blacks, and we've consulted with them and continue to other experts as well as community organizations, for guidance. And then finally, we've also engaged with the public, which is really critical. We've had a public engagement advisory council for a number of years now at ICES, but we actually convened a specific people's panel asking for members of the public who would self-identify as racialized and were interested in this work to really understand their priorities and to give them sort of some very specific questions that relate to the way in which we, specifically to our data and the way in which we do work. Next slide. The other input that's been really critical has been the work that has been long and ongoing at ICES around framework for work with Indigenous data. So this is specifically on this slide around working with First Nations data at ICES, and this framework was developed with the Chiefs of Ontario. Just by way of context, ICES, on behalf of the Chiefs, holds the federal, it's called the Indian Register, so for band information. And we have, over many years, developed good relationships and a data governance and use model with the Chiefs of Ontario, which has data governance as the center of it. And many of you will be familiar with OCAP principles: ownership, control, access, and possession. So that very much dictated how we use those data. But just to say that there was more than that. So there was data governance, which includes very formalized governance and data sharing agreements, but really a commitment to ethical relationships, community engagement, to using methods and approaches that are appropriate, so that integrate Indigenous perspectives and knowledge and models of well-being, provide context to any work that we do. And then very practically, we've also, and T spoke to this, like data collection is a means to an end, and the end should be dismantling racism, dismantling colonialism, building evidence to, build better programs and policies. And so, very specifically, we've negotiated with the Ministry of Health a funding stream so that both organizations like the Chiefs of Ontario, but even individual communities can come and request data and data analyses, as well as supporting, other types of collaborative research. So next slide. So, T spoke about this, and as we started to, really start to grapple with it, we wanted to understand, where the harms came from, and how does systemic racism kind of get into, the whole research and analytics process, and it does in multiple ways. And so we wanted to sort of better understand that. And, again, I said we don't primarily collect data, but I think we're very aware, that data comes from institutions and structures, and many of those structures are racist. And so, you need to be cognizant of that. So just to give a really, basic example, if there are, structural reasons why some people don't seek care, then if you're only using data, of the care, of those who seek care, that's already, you've already got biased data. And then, then moving into sort of how the research, even goes, like the use of the data and the interpretation, I think, very clearly as researchers, we bring our own perspectives, but biases, to play. Qualitative researchers, they have acknowledged this and, always acknowledge their personal biases when they talk about, before they speak to, how they've interpreted qualitative data as quantitative data. Researchers, that's not part of the norm. And it's very clear that we bring our own biases in. And I would just say, really specifically, and I've reflected a lot on this, having gone to medical school, and I'm old, but I'm not that old. The way in which many of us as biomedical researchers were schooled, like race and ethnicity was like a proxy for biology. And we just know that that's not the case. These are social constructs. And racism is, structural, is part of our society. And so, how we need to understand that and how questions then become framed, how you use a variable like race and what you think that means, and how you provide context. So T talked about this too, if all you have is race and you report something on Blacks, you're reporting on, at the same time, the second generation Jamaican who's a surgeon with, the Eritrean refugee who doesn't speak English, who's just arrived, in Ontario for the first time, and, people who are, who have been in North America for generations and descended from slaves. So, all of the other pieces that are going to make any kind of action, doable, requires all of that, other data around, all of the other intersections. And if that's not done, then, at worst, at best, it will have no impact, but at worst, some of this work just, ends up just feeding into kind of negative stereotypes. So next slide. So, just really thinking about, all of this, and, knowing that where we're trying to go is reducing racial inequities in service delivery and quality of care and health outcomes. But knowing that at each stage of this, there are sort of best practices that will, try to ensure that, where we're going is that goal. So next slide. So just in summary, this is what we've heard loud and clear have to be elements of the framework. So one is that, it really does need to be about anti-racist research, which involves having the research community informed, but also multidisciplinary, bringing in other ways of, thinking about the world, sociology, anthropology, et cetera. Committing to some accountability for impact, that when we're using these data, that this is because we want to connect it to mechanisms to advance health equity. Community access, so just as we have done with the Chiefs of Ontario, we do have mechanisms whereby we would be able to, provide pathways for communities and community organizations to access data analytics. And then finally, the most difficult for last, community governance, and that is a huge conversation. It is much more complicated when you're thinking about, governance around data that represent many, many different people, who speaks for those communities. But I think it's a really critical part, to how we, to the use of these data. So with that, I will pass it on.
Thank you so much, Astrid. We're going to move right to Melissa McCradden, and then we'll have an opportunity for some dialogue and questions. Over to you, Melissa.
Thanks, Rachel. Hi, I'm Melissa. I'm a bioethicist and researcher here at the Hospital for Sick Children. I'm going to be talking about some of the implications for socioeconomic data collection with respect to AI, but really what I'm talking about today can refer to just about any data-driven activity. Next slide, please. So many of you have heard me reference this study before. This was an examination of a commonly used algorithm to allocate complex care, referral to a complex care program in the United States. And what gets talked about a lot is the fact that this algorithm effectively referred Black people when they were twice as sick with a higher illness burden as white people. One of the key things that I always make a mention to point out about this, this algorithm was that the researchers thought that by removing race from the algorithm's development, they thought that they could be neutral and that they could create an objective algorithm. And in fact, this was kind of the fundamental problem with a lot of the research that we've done trying to pursue this kind of neutral or objective description of a phenomenon. Next slide, please. So I think what you've heard from the presenters today points to this idea that when we talk about algorithmic bias with AI, in fact, it's a misnomer. It is there because in AI because it is already there in the real world. AI picks up on these patterns. Click, please. And I think one of the ways that we've seen this a bit more at the forefront recently is through things like this paper, for example, by Bias and colleagues, where they describe how race currently is actually used in a number of clinical estimators and algorithms. It's used in different ways to make clinical decisions, many of which have significant concerns for equity, because a lot of it was based off of faulty research and false assumptions about the populations that we're talking about. Next slide, please. So how this shows up in AI is that the performance of different models doesn't work the same for everyone. So many of you may recall, a few years ago, one of the blockbuster headlines was that an AI tool was able to diagnose skin cancer with 92% accuracy, better than an average radiologist, and much better than most. What didn't get reported in that was that 92% accuracy was linked to fair skin. However, the accuracy on darker skin shades was closer to 40%. So you had about a 50-50 chance of getting the correct diagnosis. So papers like this have demonstrated that this one here exactly is looking at the false negative. So how many times a diagnosis was missed? And by looking at this, what's important to pull out is that the stakes are not the same for everyone. So particular to us here at SickKids, there's a lot of variation in the younger age group. And within each of those groups, there's a lot of variation across racial identity, across gender, and across insurance status, as this was done in the US. And so it raises a concern about how well the technologies that we employ, the algorithms that we utilize, are actually working in terms of accuracy for all of the patients that are served. Next, please. And so one of the things that I think we have to think about is whether poor performance of these algorithms is necessarily a harm, because it's true that there are certain patterns that we're not going to be able to correct in the context of being a hospital. There are problems related to systemic racism, economic and environmental racism that we can't necessarily completely change within the confines of our hospital. And I think there's a note of hope actually in Obermeyer's study, because he points out that when you look at the proportion of cases where the algorithm made a recommendation to the clinician without an automatic allocation, the clinicians actually redressed some of the algorithmic bias. So they observed that the algorithm's referral rate for Black patients was actually much lower than what was observed. And so it provides this opportunity for us to be able to have an awareness about how some of these patterns might present themselves at the point of care, and also to help clinicians recognize that they can have a step in counteracting some of those patterns and advocate for their patients. Next, please. So one of the ways that we can think about this is distributive justice. So one of the first things to think about is whether the benefits and burdens are distributed equally in any technology that we use. And I think through both of the examples that I just shown, we have a first step, which is the empirical collection of the information. The next step is what we actually do about it. So whether we can improve certain things just by knowledge on its own of how different problems might be presenting among different groups, we then also have the opportunity to think about what interventions could best serve those who have the highest need, and how we adjudicate between what we actually do, going from that step of seeing the data to making a decision to act, is fundamentally an ethical endeavor. Next slide, please. You can skip this one. Thanks. So what we can think about here is what are the choices that we can make on the basis of data? And my colleagues and I have thought about how really these are constrained by two different axes that we can think about this with. And the first is epistemic. So what do we really know about these kinds of patterns? So the ability to improve the fairness of an algorithm detecting skin cancer across skin shades might be ameliorated with increasing representation in the data set, with better lighting for different skin tones. But that might not be the same for something like underdiagnosis, where the patterns might relate to accessibility, they might be related to insurance status, and potentially provider prejudice as well. And this is where I think you heard Dr. Guttmann talk about, we really need to engage people who know something about these problems. So people who study critical race theory, who study gender studies, things like that. And then we have to think about how we're evaluating the model in the real world. So what impact are we trying to have, and measuring the metrics that matter, not just the accuracy of the system, but what was the actual impact to patients. Next slide, please. The way that we can go about generating accountability is through things like audits. So using this data that we have, collecting information on how our technologies are performing, but also what is the impact of those technologies. This is really important for AI and any data-driven activity. And the director of our department, Randy Zlatkenshall, often likes to say that when we talk about accountability, it's a word that's thrown around a lot, but really the important thing is that there's a specific somebody who is responsible to do a specific something. And so starting to think through the actionability of some of these issues pertaining to health data requires us to start taking responsibility and assigning tasks to people to be able to carry those out. Next slide, please. So I'd like to leave us with the words of Dr. Ruha Benjamin, who has said, beware the veneer of technical neutrality. So, and I say this because it's often not the case that we can correct for something within a system and then we can forget about it because the system has taken care of the fairness. Very often that leads us astray. I think it's really important that we enter into these challenging conversations and we start thinking through our values and our commitments to generate real change. So last slide is just a thank you to my collaborators, and I really look forward to the Q&A.
Wonderful. Thank you so much, Melissa. And I'd ask my fellow panelists to turn on their camera. So feel free to submit your questions, and I've got a few to get us going. Okay, so I'm going to begin with Karima. Karima, we've been having this conversation. I mean, you and I are by no means the first, but we've been having this conversation for a decade. Why is there still even a debate on this?
So thanks for that question, Rachel. You know, I would say that the debate surrounding the collection of health equity data is actually evolving and has evolved since those early days 10 years ago when we started this conversation. And I remember those early conversations and how difficult it was to even have the conversation about data collection. There was no openness. There was a real hesitation about asking these questions because it was felt that, first of all, it was not the role of hospitals to be asking these questions or to be collecting this data, and certainly not the role of hospitals to be doing anything with this data and addressing equity. So I think that you know, the conversation has actually changed, because what I've seen over the last 2 years, and I have no doubt that this has been influenced by world events and the pressures from those world events, starting with the murder of George Floyd. What we've seen is almost a demand for this data, and the conversation now has become, why don't we have this data? Which in some ways to me is also problematic because it raises some flags and new worries about the care with which the data will be used. And so I think that, you know, there's a new debate starting around that. I also think that, you know, the bigger question now, and maybe this question's always been there, is there enough commitment to demographic data collection to the point where we're willing to actually dedicate the types of resources that are required to do this well and to do it carefully, and to not only collecting the data, but then using it appropriately with you know, the engagement of communities to address the disparities that I have no doubt will continue to find.
Thank you so much, Karima. I'm going to pivot us a little bit and talk about language. This might be a session on data, but it's hard to imagine that language isn't a key component of this. And I think many of us over the last decade have used terms like socio-demographic data or equity. And there is a shift to starting to talk about what this will unearth in terms of systemic bias and racism, and really getting at, and, you know, Astrid, you rightly used the term colonialism. What do you think do you think there's importance in the language that we put around this discussion and people's understanding of the salience coming out of it? I'm gonna start with you, Astrid.
Yeah, absolutely. I think, you know, again, I was trying to make that point about, you know, even the word, you know, race, like, what do you mean by race? Like, what does that mean to you? And, you know, it should mean racism. And so I do think that using words, again, I'll just reflect, you know, we, like in the biomedical world, I don't think we think about language. You know, I actually would be interested to hear what Melissa has to say. I think other disciplines talk about how, how important language is, because it's really like what are you actually talking about, right? And you know, and so so I do think that language is is very important and reflects, a lot of things. So I'd be interested in, others' thoughts on that.
Ask T if you'd like to weigh in on this one.
Sure. T.
Thank you for that, Astrid. Yes, I am a big believer that language is very important and powerful in how we use it. And I've often pushed back on this concept of race. We know it's a social construct. We know it's not has any kind of biological inherent differences, but yet we still use it. And so I quickly just did a Google search as to when it came from. And the 5 groups of races were, and I'm going to read it, a Negroid, which is a black race, an Australoid, which is Australian Aborigine or Papuan, a Capoid, which is a Bushman or Hottentot, a Mongoloid, which is Orientalism or American Indian, and a Caucasoid. And so when we even think of the history on this language and how we continue to perpetuate it since the 1700s, we have to ask ourselves, can we not go further? Can we not do better than to use language that no longer fits, that comes from colonialism and is very color-coded to perpetuate the systemic oppression of these groups that have deferred who is the supreme race? And we see that in regards to the language and based on white supremacy, which is based on policies and procedures, not simply about, cross burnings and sheets, but how it continues to be operationalized in our policies, in our practices, and how we support issues of human rights and concerns, and based on who is valuable of our race-based conversations. And so I think these conversations about race is very important, and to dig deeper into understanding social political identities as opposed to just this color-coded language that allows us to maintain neutrality, which is problematic in and of itself. And so I would actually turn to Melissa and say, can you add from an ethics point? Because we often confuse ethics with equity also, and they are very different, but incompatible and complementary.
Melissa, maybe you can add to that and also comment on, you talked a little bit about distributive justice. And, we have a health system that is arguably a bit more grounded in a utilitarianism model of the maximum benefit for the maximum number of people. And to what degree do you see those at odds when we're talking about groups that are systematically oppressed?
Yeah, that's really interesting. I have a lot of thoughts on that. I'm going to try and keep them in mind, because one of the things that I noted, I was reflecting when T was talking earlier about the majority versus minority, because one of the other things about language, about race and ethnicity, is not just how we refer to people's ethnic heritage, but who doesn't get a label of ethnic heritage. So when we're talking about, very often it's person, or they get an identity. And so it's kind of a white erasure that sort of maintains the notion of whiteness as the status quo. And so I think that's also a problem as well when we're thinking about, because you're othering people, right? So rather than embracing a spectrum, you're saying there's these people and then there's these other groups as well. And so I think that's a problem just in terms of how we conceptualize these things in our own minds, how we develop schema as we encounter the world, because even when we're talking about research, then it becomes this like additional step that we have to do to include these other groups. Whereas if we were really embracing this notion of a spectrum, we wouldn't be thinking about that. It would just be a thing that we do where we include all these people. And to your point, Rachel, about consequentialism, I think it's interesting because I think one of the commonly cited examples is the proportion of people affected by sickle cell versus cystic fibrosis, and how actually there's a similar disease burden and yet a disproportionate allocation of funding. And so I think about, one of the ways that we could really kind of deal with this is to just go where the need actually is. And that's, I think, what equity is about. It's about saying there is a need here. Some people are disadvantaged relative to others. And so we do disproportionately allocate funding, because I think that less consequentialism, more like people think that our status quo is equality. And in fact, it's not. And so when you get the idea that we have to change the status quo, people think that you're changing equality. But in fact, that's not really what we're doing. Sorry, that was a little bit rambly, but.
No, it wasn't. I'm seeing a whole host of questions come in, and I'm going to pick on one from Rochelle Maurice about trust. And she's written, historically, people from racialized communities were extremely reluctant to disclose demographic information for fear of harm about how it will be used or misused, as well as disparities in how they will be treated as a result of those disclosures. What are some methods of engagement that will be employed to facilitate trust and ensure transparency? Who wants to take that one? It's a great question.
Sure, I'll start. I think I will refer back to how we've engaged COVID, and in a word, we know that folks, who are the COVID hesitancy group, we continue to group them into this demographic as the COVID hesitancy community. But why are they hesitant, and why are folks more likely to take a risk with their health and their mortality than trust a system that says it's safe this time? So what has been done to engage, to support the community reparation as to why they don't trust the system? Why would communities take their chances at losing jobs, at losing healthcare, at losing family versus trust a system? So then I guess that my question is what have we done to prove that we're anti-racist? What have we done to prove that we've made changes? What have we done to create systems of safety, inclusion, and representation that goes beyond just the data collection that says this is who we are, we know who we are, but what are we using that data for, and how are we engaging in that, reconciling the truth to create the restorative justice and reparations that we need to do when we talk about data collections, particularly for marginalized communities who have used that data to be commercialized, extort it, and exploit it, but have never been seen as being part of the collective and community. And dare I say, when we move past needing the data collection, that I get to just be any other professional has versus a really great Black executive. So when we have these qualitative and quantifiers to distinguish different, but still say you're great, has a different person, then that's that space where we create safety and reparations by acknowledging how we have not engaged and continue to harm by denying our engagement.
So I'd like to, that's a really good segue, and I'm going to turn to Astrid. Over the past year, I think with COVID, we have done more discussion of sociodemographics and race in the context of COVID. Do you feel like it's made any difference? And what would you like to see in terms of how that would have been used or will be used moving forward? You're on mute, though.
Sorry. I guess maybe I'll take, I actually think COVID's a really interesting example of how you can work on some of the superficial issues, but the big issues are much harder and less, require a much deeper reflection and action at the level of society. So I'll just give as an example, work on vaccines. So when we first got the vaccination data, the first thing we did was we said, who's getting vaccinated by communities, and we ranked the communities by their risk of COVID. And it was very clear because at that point, our policy was everybody, it's like per capita, every public health unit gets, based on their population. And we showed very clearly that, in the initial phase, early on, more people in low risk neighborhoods, like the ones most of us probably live in, were more vaccinated than others. And so, it was, that fed into kind of a change of policies and a bit of redistribution. But, that's kind of easy. It's not easy to vaccinate people. I get that. But it's really, if you think about that, why would people care? They care because our whole society was shut down, because they could actually get sick from somebody else, so there was so much self-interest actually in those decisions. And I still laud those decisions. So think about other things. So, we did a lot of work early on around some of the groups that were getting COVID, and in particular tied into our immigration system. And, we showed very clearly that, this group of predominantly women who come in as economic caregivers, this pathway, who are often trained as nurses, come in from the Philippines, the Caribbean, they had huge, and then are the staff, in long-term care homes, had high rates of COVID because of, their occupations. And when you dig into that deeper, many of them are casual, they have no sick leave, they have no benefits. Many of them are working in professions that are actually less than what their professions were, before they came. That's structural racism, right? That is kind of our immigration system, our workforce. So how do you, taking that on and like being, and the policies that would sort of redress those are much larger ones. So I would say, do I hope we go there? Yes. Have we gone there? Not really. So anyway, that's maybe, also feeling a bit rambly, but, so I think I'm optimistic that we've moved a little bit. But I think like on some of the really big fundamental, ways in which structural racism pervades our society, I don't know that we've gone there yet.
So I know we're almost out of time. So I want to just leave with one final question. What do you think it's going to take to any of you who want to answer this for us to actually take action on this? And one of the questions in the chat is, what will it take for us as a medical community to treat people as humans with a spectrum of identities instead of siloing individuals? So I don't know if anyone wants to jump in on that. I know T, you have to go, but I feel like
I do want to say something. I think we are doing what it takes by having these conversations. I think by many folks know that Rachel and I are working together to create the first employee data collection at SickKids. And so we are doing the critical conversation. So I want everyone to feel like we are part of the change by engaging in these ongoing conversations and knowing that the heavy lifting has to be shared by all of us. Thank you, everyone. My apologies for my rude exit, but I've been flagged that I'm late for my next interview. Thank you so much. Ciao.
Rachel, if I can just really quickly add, I think it's really unfortunate, but it's the events of the last 2 years that have actually gotten us, I think, to this point and is prompting us to actually take action. So whether it's the death of Joyce Echaquan or George Floyd, I think these are really significant events that have raised awareness of the racism that exists in our healthcare system and the need for us to be doing more. So I agree with T that I think we're beginning to have these conversations. There's definitely a lot more to be done, but I think we've taken some important first steps.
I will say, I had a couple questions that I didn't get to, and there's several in the chat. And one of them was going to be about how we think young people today, teenagers and tweens and younger kids, what is their comfort level with sharing this? And I know, Melissa, you probably want to weigh in briefly on this, but I'll say if we can one day have a panel where we ask young people what they think about these issues, I know we'll get even further. Melissa?
I gotcha, yeah.
Final word from you.
Yeah, we're actually running a study right now asking children and youth their thoughts about data sharing, particularly for the use of AI, for the use of research. So I'm really hoping that we get some good insights there. And as to the children of the future, like I just look at my children and the fact that they know that one skin color is not like the skin color crayon, that there's all different skin colors and that they have options of different figures to play with at school and that they know these differences and they can name these differences. Whereas like, I think I was probably almost 30 before I was comfortable talking. I'm still not comfortable, but talking about these things. Like our kids are so much better off than we're going to be, and they know what's going on. So I look to them to help us with this.
And Rachel, if I can just add to that, the early work we did in developing our pediatric data collection instrument here at SickKids, I think we had 2,000 patients and families that we piloted the tool with. And the overwhelming finding was that about 97% of patients and actually their caregivers were comfortable sharing their data. But it was staff that was not comfortable actually asking the questions and collecting this data. So I think there is a comfort level, certainly amongst teens for sure, but I think even amongst families, as long as the purpose of data collection and how we're going to use this data is adequately explained to them.
Great. Well, I want to thank everyone. And I know that we lost a lot of people because we're a bit over, but remind folks that on December 8th is the next Health Equity Rounds, I believe, and Dr. Catherine Birkin will be moderating, and it's about food insecurity. And thank you. It's now up on the screen so that I don't have to remember it. And Dr. Metavan Denhuel and Francine Buchanan will be speaking, and I would encourage everyone to join. And thank you to Karima for giving me the privilege of moderating this session.